Hello, everyone, and welcome back to LIMBWatch, the series where we spotlight the innovations, experts, and the ideas shaping the future of limb preservation. I'm your host, Dr. G, and today is an absolute pleasure to welcome an outstanding leader in wound care. Joining us is Dr. Dawn Franceschina, I am so sorry, who serves as the Vice Chair of the American Board of Wound Management Foundation. Dawn is a physical therapist at the Wound Care Center at Advocate Lutheran General Hospital in Park Ridge, Illinois. She has been working with patients in the inpatient and outpatient areas of wound care for the past 29 years. She is also a former guest lecturer at Northwestern University, teaching wound care to students in the Doctorate of Physical Therapy program. She has also lectured on the topic of wound care at many different continuing education conferences over the span of her career. Dawn has received her certified wound specialist certification from the American Board of Wound Management in 2002, and she currently sits as the vice chair of the American Board of Wound Management Foundation. So it's truly an honor for us to have you, Dawn, and welcome to Limb Watch.
Thank you so much for inviting me on. I'm really honored to be able to be here, both for myself professionally, but really also to help represent ABWM Foundation and just to be able to talk about wound care. And I'm excited to be here. So thank you so much.
Oh, thank you. So, Dawn, can you tell us about your journey into wound care and what inspired you to dedicate your career to this field?
Yeah, absolutely. So I graduated high school back in 1992, which you can do the math and then figure out how old I am. And I just I decided that I wanted to go into the field of healthcare and decided on physical therapy. And physical therapy at the time was difficult to get into. So as I was doing like all my gen eds, I also worked as a physical therapy aide at a clinic. And it was primarily outpatient orthopedic, but they did a little bit of wound care. They had like one of those old extremity whirlpool tanks there, which we don't even
Mm,
use anymore, but
yeah.
it was like real old school back then. So anyway, so we were seeing a couple of, it's primarily ortho, but I was seeing a couple of wound care patients just helping out the PT that was doing some of the wound care. And A, it highlighted that like, wow, I didn't even realize PTs can do wound care. And B,
Mm.
I was fascinated by it. I loved the visual part of seeing something heal. I loved the gratitude and just that gratefulness that patients have when they see their wound heal because it has such an impact on so many aspects of their life. And so I was hooked. That was like before I even got into PT school. I was, like I said, I was just doing my gen eds. And then I got into PT school and I said, I want to do wound care. And everyone looked at me like I had, 8 heads because like who wants to do PT and do wound care right off the bat? So sure enough, I graduated from Northern Illinois University in 1997. And my first job, which was at a trauma hospital in the suburbs of Chicago, I said, I want to do wound care. I just love how visual it is. And they had a wound care nurse that was there, WCN, but she was so heavy and ostomy. She was happy to help train me up and kind of hand the reins over to me. So I just did a ton of continuing education and then had her mentor me and like got physicians to trust me with their patients as I was seeing them maybe for mobility. And then I would sneak a peek at their sacral pressure ulcer or at their diabetic foot wound. And I would
Wow.
ask vascular, attending and if I could work on the patient's wound. And I got a few to trust me and I took and ran with it from there. And it was just very, very gratifying. I loved it. I loved seeing the visual healing process. I loved the holistic manner at which wound care really thinks about patients, their medications and their medical comorbidities and looking at lab values and really thinking about a lot of aspects of who that patient is and the care that they're receiving. So I was hooked. So starting in 97, I was hooked and I've really done wound care my entire career. I've done other areas of PT a little bit, but I've always done wound care kind of throughout my career. And for the past 20 years, it's just solely been wound care. I tell people I don't feel like I function like a normal PT anymore. So, but really, it's been such a rewarding career, and I've loved it. I'm so grateful that I've been able to do this my whole career.
That is so fascinating and
Mm,
incredibly unique. Wow. So
yeah.
what excites you the most about wound care today compared to when you first started?
Oh, yeah. I mean, when I first started, it was, the wound vac came out in 1995. And so I graduated PT from Northern, and I ended up going on and getting my doctorate through Boston University in the early 2000s. But I was practicing as a PT in 97 at that first job. And the vac was just new on the market. It was the only one delivering negative pressure. And it was really, I feel like, the first thing that was taking more of a passive wound healing process and making it into something more proactive, and
Mm.
it wasn't just putting a foam or an alginate or, something like that on the wound, but it was like, oh, taking a modality and saying like, I can heal your body. I can heal this wound faster than what your body can do on its own. And that was exciting. And the first wound vac we placed was on a lady with Fournier's gangrene. I mean, it was
Oh,
literally
wow.
probably the worst case. I mean, she had this massive excision of her perineum and it was massive. And we had the rep come in. And so anyway, it was a trial by fire experience for sure. But I love the fact that wound care is evolving with research and it's evolving with technology and innovations where we're taking this more passive process. And we've gone from negative pressure, which again was probably the first example in my career. And then it went into Regranics, like a platelet rich, a platelet gel where you could put it on and it had growth factors in it. That was exciting. And then now it's evolved into these dressings that have this beautiful technology that don't strip the skin when we pull them off and manage the exudate and the bioburden. It pulls the, bacteria up and into the dressing. And this is really, really great advanced dressings. And now we're moving into, right, we've been in the land of CTP, cellular and tissue products, and platelet-rich plasma. That's been the last, 15 plus years of practice. And that's helping to push things forward even faster than the body can do on its own. And, the future is like, I feel like limitless. You've got AI out there, of course, and how we're going to use that in a way that's responsible and ethical for our patients. But you've got, these other things. You've got targeted therapies that are coming out that are in the research and development stage right now that are going to look at like the biological and the cellular and the molecular determinants of healing and then how do we personalize that therapy to like that patient's particular biochemical needs? I think that's super exciting. I mean, think of that in the field of oncology and how that's really transformed patients in their treatment of their cancers. I feel like that's where wound care is going as well. And that's exciting. But yet, at the same time, like all of those foundational principles still are always going to be foundational. They're always going to be important. So we think of nutrition, we think of
Mhm.
offloading, we think of pressure relief, compression, edema control, bioburden control, moist wound healing principles. Like we can put the best, most expensive technologies out there, but these things are never ever going to go away. Those things are like adjuncts, right, to those
Mhm.
basic foundational principles. But it is exciting to think of something very individualized for the patient where we can actually assess their MMPs and we can assess their pH and we can assess, what's happening from a biochemical perspective for our patients and apply that. So yeah, so that's exciting. I hope in my career I still get to see that, in the next 15 years, but we'll see.
Yeah, yeah, definitely.
Yeah.
So,
Yeah.
what is Wound Healing Awareness Month, and why is this so important?
Yeah, so Wound Healing Awareness Month, or WHAM as we call it, was started in 2016 by the ABWM Foundation. So just to differentiate, the ABWM is the organization that helps with certification of professionals in achieving their certified wound care specialist, their CWS or their CWSP for physicians, or CWCA, certified wound care associate. So the ABWM Foundation specifically helps to support the works of the ABWM. And so the foundation was able to develop WHAM in 2016 as a way to generate awareness to the general public about just how chronic wounds really affect 6.5 million Americans every year. I mean, it's not just like a little drop in the bucket. It's a ton of people, right? The walking wounded that we see that are walking around with that venous leg or that diabetic foot or that sacral pressure ulcer, we see this impact so many of our patients. And so we want to raise awareness of the impact of chronic wounds on so many people, and also to recognize the specialization and the efforts of wound care clinicians that are in healthcare today. How many of us have heard from our patients like, I didn't even know wound
Uh-huh.
care existed until my doctor sent me, or until my brother had, weepy legs, or whatever. Like, wound care is still a very under-recognized specialty in the medical world. I think that's gaining momentum, but it's just helping the general public to be able to eradicate that lack of awareness, really. And we do that primarily through social media during this month, but we also encourage clinicians on their own, kind of a grassroots level, to spread that message through posters or digital downloads or backgrounds for video calls. We've got t-shirts, and just really want to, get that message out there a little bit more strongly, a little bit more frequently, and really help to celebrate those clinicians that have gone on to become, wound care specialists, and recognize that their works are not their work is not in vain. Like, they really, really make a difference in so many patients' lives.
Thank you, Don. That's amazing. I love Wham Month. So, what are the
Mhm.
misconceptions about chronic wounds would you like the public to understand?
Oh, yeah. Yeah. I mean, I feel like it's one of those things that until you or someone has gone through it, and you realize how multifaceted a chronic wound
Mhm.
is, and the impact it can have on your life, I think it is hard for people to really understand. Wounds they still have this kind of stigma around them, right? And so people don't really understand, like, what does it mean to have an open wound? Like, I tell people, in various parts of my life, I do wound care, and they have to ask you to repeat it, right? Because they don't understand what you're saying. And then they say, wounds, oh, like a burn? Like, okay, well, maybe, but, like, let me kind of tell you a little bit about the patients that I see. So as I think of my patients that come into the clinic, that I'm employed at, I think of those impacts on their life, of, like, how they or their family members have to be responsible for caring for this wound at home, like doing a dressing change, or how much time the patient or their family members have to take time off work for visits or hospitalizations or diagnostic tests if I need them to go to the lab and to get x-rays or imaging or something like that, like how they have to take time off work and really make their life work around their wound. The financial burden of copays and
Mhm.
dressing supplies, or clinic visits or tests, the anxiety my patients hold, really, as they try to hide their wound from the world, because
Mhm.
people they just unfairly judge them as being like unclean or infectious, and that goes way back to biblical times, practically, where people with leprosy were deemed unclean, and just really the stigma that still holds. And so, there's long-term lifestyle shifts that people may need to do to reduce that venous ulcer from coming back, or to reduce their gait so that wound doesn't return on their foot. So I guess what I would love the public to have is just a general level of understanding, and also compassion for
Mhm.
patients that are going through chronic wounds, because it's tough. It's tough to see patients go through it. It's tough to watch a loved one go through this. But what if we, like the general public, could just have more support and more empathy for these patients? Just being willing to listen and maybe engage it, and not, like, pull back because you're worried you're going to catch their flesh eating disease, right? We've heard that so many times, but we can actually kind of just enter into their situation, and try to understand a little bit more, and support them. How many of our patients really need that support? They need the family member, but if they don't have the family member, maybe they need a neighbor, or they need a coworker to be able to help. And so, yeah, just to have a little bit of empathy, and compassion, and to be able to help, and support that person in whatever way that they can.
That is such a good point, Dawn. I thank you for actually even saying that about the person who has a chronic wound, and how they feel while they're in society. Thank you for actually bringing light to that. That's actually so important because you're
Mhm.
telling the absolute truth. So,
Mhm.
what? So you're a physical therapist and a wound care specialist. So, what
Mm.
unique perspective does that combo bring to wound care?
Yeah. I mean, I think it's great, but of course I'm real biased. So yeah, I'll talk about kind of me as a PT, but then I know we're going to talk a little bit about kind of that multidisciplinary aspect to wound care that I think is so important. But as a PT, I believe that as at PT, the way that our education, with the way that the curriculum is developed and the models in which PT programs are oftentimes driven is through this level of kind of autonomy in how we practice. Not that we practice in a bubble, but that we are really independent thinkers and critical thinkers in all areas of our practice, whether it's wound care or outpatient ortho or pediatrics or whatever. But I think PT programs set us up to have that autonomy and that critical thinking skill. When I do my wound evaluation, which oftentimes is just done by me itself, the physician refers the patient to our clinic, and then I'm the one doing the evaluation. And I have lots of different resources out there. I have an APN, I have wound care physicians, I have vascular and ortho, and all of the specialties that I need at my disposal. But oftentimes I'm doing the eval. And so when I'm doing that evaluation, I'm so much in my eval, probably 75% of the time that I'm with that patient is asking questions, like question after question after question. And I'm a digger. I always say the best wound care clinicians are like wound care, like a crime, solver, right? Like
Yeah.
we're just,
Yeah.
and just
Definitely.
getting,
Yeah.
yes. Yes, I love it. Like, because the patient tells you the story of how it
Mhm.
started. And then half the time I look at it and I'm thinking, I don't think that's accurate. But people want to put a cause and effect together. And so, you see that all the time with diabetic
Mhm.
foot. It's I
Mhm.
stepped on something and you look and you're like, well, you've had a callus here for months. And so I'm
Yeah.
not so sure. So anyway, but we spend that evaluation asking about onset. How did it start? How long has it been there? Is it getting better or worse? Show me pictures on your phone. I love that people can show me pictures on their phone of what it looked like when it starts, right? And then what it looks like currently. So, and then we just dig and dig and dig, right? And I know you do this too. I've heard this on your podcast, right? You dig and dig and dig until we have a really full understanding of what contributed to its development. So I think as PTs, we do that critical thinking, but also as PTs, we think of prevention. Like we really want to think of like, how do I get this better? And how do I keep people from having this come back again? And I'm not saying other professions don't do that at all, but I just think as PTs, we are so preventative focused. And we also assess the patient very holistically. Like I
Mhm.
understand lab values because in my training, I learned lab values. Now I don't know them as well as a provider does, like you or a physician or an APM, but like I understand it. So I can look at labs. I can think of, them holistically and what's keeping that wound from healing. Not only thinking about the pathophysiology of what's causing the wound, but other aspects, including like their function. That's, I think, a good PT attribute as well, as we're always linking things back to their function. So like the patient's gait distances, like do they walk 2 miles from the train station to their job? And that diabetic foot might not be able to handle that. So like, how do I think about their functional mobility so that I can get their wound to heal, but yet still get them to work? We think about sleeping positions. We think about pressure relief. We think about social determinants of care, as again, I know a lot of providers do as well. We think about pain control and again, how it relates back to function. And then there's a specific ways that I think PTs are uniquely trained that can really bring significant value to a wound care team. I think, again, we can do education on positioning or different equipment, different, ways to be able to help with pressure relief or for something like a pressure injury or different gait devices to be able to help with offloading. But we can also provide a level of expertise in the realm of, like lymphedema, and not just primary lymphedema, but secondary lymphedema that may help patients with venous leg ulcers. We know a lot of patients with venous leg ulcers have a secondary lymphedema. So what are those lymphatic techniques that PTs are uniquely trained on that can help patients? And then again, offloading. So offloading the plantar, neuropathic foot. So what are the understandings of the biomechanics of gait that can help with pressure reduction on the foot? We work with the podiatrist, we work with the orthotist with offloading that neuropathic foot. We can provide recommendations for shoes and inserts and braces and range of motion and, calf raises when my 90-year-old barber patient is standing at work with that venous leg ulcer, and how do I activate that calf muscle pump? So many ways I think PTs can be a really integral player in the team of that wound care patient. And I wish there were more PTs that were
Mm.
able to, step up. And that's part of what I want is for this half of my career is to really help encourage PTs and clinicians in general, but to really be that integral part of the team, because I think we have a strong role that we can play.
Well, thank you so much. I feel like you're like in the Olympics of wound care because you're
Mhm.
opening my eyes to the PT aspect of it, and it's fantastic. So, why
Mm.
is interdisciplinary teamwork so important in wound healing? You talked a little bit about it just now, but
Right. Right. Yeah, absolutely. I mean, wound healing, if we really think of like all of the medical specialties, cardiology and pulmonary and orthopedics and oncology, I mean, oncology probably is comparable, but like wound healing involves so many body systems. Like I feel like nothing is excluded. Like everything really matters when it comes to wound healing. That pulmonary system, that cardiac system for sure, the peripheral vascular system, of course, orthopedically, I'm not a specialist in all of those areas. So, just take that diabetic foot ulceration. So that patient that comes into your clinic and they've got that first MTP, ulceration, they've been diabetic for 15 years, their A1C is 8.2, that person absolutely needs a PCP and needs a podiatrist. Like that's no question about it. But think of all of the other things that that person might need. They might need an endocrinologist if that PCP doesn't want or can't handle that glucose control. They might need a nephrologist if they've got, early kidney disease happening. Maybe they need a vascular surgeon. Maybe they need an orthotist. Maybe they need a cardiologist. Maybe they need a PT like me or a wound care specialist in general. Maybe even infectious disease, let alone any other medical conditions that they have. Heaven forbid they also have CHF and they have, all of the
Mhm.
other things that kind of come along with that diabetic patient. So really wound healing truly works best when we involve not only the right team players, like we need all of those team players because these patients are complex and we all bring something really unique to the table. But we also have team players that know what their lane is and they stay in that lane. I mean, I'm not meaning to be mean about that, but like that we all respect each other's role in that team. And, like I am great at managing that local wound. And so I understand the dressings and I understand debridement and I understand that local wound care piece really well. And so I really don't need the vascular surgeon to tell me what dressings to use. Like I don't because I know what to do. But I don't need to tell the vascular surgeon how to do their revasc. Like they know how
Uh-huh.
to do that. I might tell the vascular surgeon like, hey, this gangrenous toe is not getting better. Can you take a look and see if you can, do something about it? So I work collaboratively with
Mhm.
all of those team members, but like I'm not going to tell him how to do his revasc. That's his job. So we stay in our lane, but we collaborate and we give each other that respect that we deserve. I'll give you like a little example from my current practice. So a podiatrist that I work pretty closely with, he referred a patient to me that had a midfoot Charcot, like an acute midfoot Charcot collapse with a midfoot ulceration. And when I probed it, I probed right to bone, like right off the bat. And the podiatrist is like, his foot's like crumbling and it's really kind of a mess in there. And he had done a bone biopsy and the biopsy was positive for acute on chronic osteo. And so when he referred the patient to me, the patient had already seen ID and was on IV antibiotics. So it's great, So this is like truly limb salvage, right? We think of
Uh-huh.
this is like classic limb salvage. I was able to suggest to the podiatrist who was referring the patient to me for negative pressure. I said, well, what if we do total contact casting? Because I feel like that's really the patient can't maintain non-weight bearing. He didn't have a crow boot kind of on board. He was like trying to get around in a cam boot, but he couldn't do non-weight bearing. I said, let's do total contact casting. I'll see him twice a week for TCC changes and I'll do all the local care. Let's get him a hyperbaric consult. He's like, oh, this is a good idea. And like we've made some really nice progress with this patient's wound and it's still ongoing. So I don't have kind of the ending to this, but it's all that team. It's me and it's ID. And thank God he's got good vascular flow and he's got an amazing social support. But like it's all of us working together. Like when the ID transitioned him from IVs to orals, I was able to talk to ID and say like, hey, can we definitely think about keeping him on orals through the total contact casting process, because like I would love to keep him covered. And he was able to take that and use that information to make his clinical decisions, the ID doc, as to how to manage that. And so like that's where multidisciplinary, interdisciplinary wound healing is at its best. Like not only do we have the right people, but we respect each other. And, I bring my expertise to the table. All of these other people do. And it's a beautiful thing when it works well. And unfortunately, I've seen it where it doesn't work well too, right? But I'm just really grateful to be part of a team and a practice where there is this mutual respect and this mutual understanding of the roles that we play. I think of wound healing, I've given this analogy several times, like if we think of a wheel, like a wheel on a bike, and wound healing is the center hub, like that's the goal of what we're going towards. And for that wheel to turn smoothly, we think of all the spokes that are leading into that hub. So if wound healing is in the middle, we think of nutrition as one of the spokes leading in. And we think of, let's just say in the diabetic, we think of glucose control. We think of vascular status. We think of their cardiology status. We think of their renal status. We think of all of these spokes. And if we don't address all of them, that wheel is lopsided. Like it doesn't roll. It doesn't work as efficiently as it could. And so if we really look at all of those spokes that are contributing, social support, their functional status, their range of motion, all of these things, I feel like if we as the clinician really assess all of those and address all of those, and that's where that wheel can like really turn. And then wound healing, that central goal, can really be achieved. But like otherwise it's lopsided. If I'm hitting 50% of those, if I'm hitting 75% of those on these complicated patients that are multifactorial, like you're just spitting in the wind. I feel like you just aren't going to really get that smooth rolling, forward momentum that we're looking for.
Oh, wow. Yeah, Dawn, you sound like a superhero. I'm not gonna lie. So, like, I would want you on my team. I'm not gonna lie. So, okay. So, why is board certification in wound care so important? In my
Yeah. Yeah. Well, I mean, I think the big question is, why is board certification in any specialty important? Really, it's that voluntary action by the clinician to say like, hey, I want to specialize in this area and I want the recognition for that. It recognizes that clinician as having a level of clinical expertise and experience in that area, which promotes so many things, improved care to our patients, like because we've just got that level of knowledge. It shows dedication to excellence, because of course when we're board certified in something, there's typically a continuing education requirement that comes along with that. Like even for my CWS, I have to do 6 hours of mandatory continuing education specifically in wound care. It promotes this continuous learning. Again, this idea that like, I got to stay up on what's coming out in the area of wound care. I want to stay up on, like these days, it's like, oh, how is AI going to affect my wound care? Like that's one of the things that I'm starting to really, wrestle with. And then it also makes sure that we, when I'm board certified in something, like I'm elevating patient safety. I'm really thinking like, I want that patient not only get the best care, but I want them to be protected and safe in the care that's being delivered. So patients benefit, by me being certified, not only by the quality care that they receive, but they have that assurance. Like if somebody walks in and they see my little certificate on the wall, they have assurance that there's a standard being set by an accredited organization, and that clinician has met that criteria established by documenting a set number of years of experience, by passing an exam, and then committing again to this annual continuing education process to maintain that credential. And so, that patient is reassured like, oh, this is just not, Joe Schmo that's doing my wound care, but like she's achieved this level of expertise and of excellence by having this credential. So, and the healthcare system benefits from it. It sets the bar. It sets the bar for the clinicians. Like this is really a minimum of where we want you to be at, that we want you to have this wound care knowledge and expertise. And some, healthcare organizations are requiring a specialization, a wound care specialization credential for their clinicians, which I think is great because it's like, nope, we are just not willing to accept anything below this. We want you to know, we want to know that you've been trained. We want to know that you've passed this exam. We want to know that you've got these years of experience. We want to know that you're going to continue to grow and learn by having this requirement for continuing education. So, industry and research, they all benefit from us having board certification in wound care. And so, yeah, it goes along with any other medical specialty that decides to get board certified. I think it's just that recognition and that's that bar being set at a minimum standard. And I think it's great.
Yeah, no, I mean, I definitely have utmost faith in anybody who has those last abbreviations at the end of it
Mm-hmm.
because the exam is actually very extensive and you have to dedicate yourself. So thank you so much.
Mm-hmm. Mm-hmm.
What advice would you give clinicians interested in becoming a wound care specialist?
Yes. I would just say yes. Go for it. I'm biased in my love for the ABWM and for the foundation. I mean, the ABWM offers the CWS and the CWSP and the CWCA, which is an accredited exam. I mean, all of those certifications are accredited by the NCCA, which is the National Commission for Certifying Agency. It just says we meet these criteria that we review the exam and we have a really extensive process for developing the exam and the test questions that come along. And so like we're a really great organization. The accreditation is a really specific designation that I think that our wound care specialization carries. And yeah, it's a rigorous exam. It's not just I'm going to pass it on the first time I take it, but it takes some effort. And so I would say go for it, but don't go into it just thinking like, oh, I'm going to cruise through. Like, no, prep for it. Go to those continuing education courses, the SAWCs and local courses. And there's so many great wound care courses out there. So go. Like when I first started, I just went to course after course after course, and I was just absorbing it all. Start reading articles in these peer-reviewed journals and maybe start a journal club at your place of employment so that you and some of your coworkers that are equally geeked out about wound care as you are, you guys can collaborate together and really talk that through. Maybe you find a wound care mentor. I think
Mhm.
having a wound care mentor was instrumental in the start of my practice. And so having somebody that can just guide and shepherd you through that, yes, absolutely. Get some of the ABWM Foundation educational resources off of our website that can help you in preparation for your exam. Take the prep course. Like there's so many things you can do. But like, yeah, if you are passionate about wound care and you just are equally geeked out, like I said, as I am about doing it, like, yeah, go for it. Go for your certification, get a mentor, go to courses, journal clubs. There's, foundation website, lots of options out there for you. But yeah, prep for sure.
What is the
Yes.
most rewarding part of helping patients heal?
Yeah, I would say just the relief that patients have and the joy, and not just the patients, right? It's their family members too, because this is oftentimes a group effort. So, it doesn't just affect the patient, but their family members too. And so just that joy and relief that they have once they experience closure, like, "Oh, I'm not gonna lose my foot," or, "Oh,
Mhm.
I can take a shower again," right, without worrying about infection or, so it's just that relief. And as we know, so many of our patients, this is a chronic condition. Venous and diabetic are probably 80% of the patient population that I see. And so, yeah, it becomes the like, "Okay, yes, this is close, and, like, let's absolutely celebrate this together." And yet, on the same breath, it's like, and yet this doesn't mean that you're off the hook, right? And now it means you have to wear the shoes. Now it means you have to wear the compression. It means you have to elevate your legs. All the long-term chronic management things that we have to do for any chronic condition. That education piece, that follow-up piece with people. I love it when I can have patients come back 2 or 3 months post closure and just take a look and say like, okay, how are things going? How's that edema? How's that diabetic foot? Did you get in to see the podiatrist? But the reward of seeing that relief on their face and their family member's face, that's definitely the most rewarding part for me.
So, what is the biggest barriers preventing patients from healing?
Oh, yeah. Well, I think there's a lot there. I think in the rural setting, access to care, transportation, if that wound care clinic is 30 plus miles away, that's
Mm,
just gonna be hard, for people to be able to get there on a regular basis. I'm pretty spoiled living in the Chicagoland area. I feel like not only do people have pretty good access through the public transportation system or through, ride share, like Uber kind of stuff. I think people can usually get to our clinic, but I know that's not always the case. So I think access to care, again, especially in the rural setting, financial for sure, and it's not
uh-huh,
getting better, right? As we know this, like copays
mm,
are getting higher. I just had a
mm,
patient the other day tell me that their deductible was $12,500 on their plan, and I thought, like, that's insanity. Like
yeah.
$12,500 for deductible, Or I had a patient recently that I went to go submit for a CTP, a cellular tissue product, and they had $1,000 copay per application, and I thought,
Oh
well,
my gosh.
insane, like $1,000. So that financial barrier of like, man, I really want to put that advanced product on, and they
Mm-hmm,
have $1,000 copay, and we can't do it. We just straight up can't do it. So medication copays, that kind of stuff. So that financial piece, and then I know I'm beating a dead horse, but social support. I think the lack of social support, especially I don't know. In the area in which I practice, I feel like people can be a bit isolated sometimes. And so I don't know if that's everywhere, but at least where I feel like if I have got that 78-year-old guy who is a widow and or widower and he just doesn't have contact with his neighbors and his family isn't in the area or something, it can be very isolating. And sometimes that not only is a barrier to healing, but maybe is the biggest barrier is keeping him closed long term, so the social support, transportation, financial social support, I would say, and then
mm-hmm.
insurance coverage in general. Yeah, there's a diabetic shoe bill out there, but it doesn't fully cover things a lot of times. And something like a venous leg ulcer, like you have to have an open wound to get coverage. I think that's silly. So some of the insurance stuff is just, you got to navigate the system and work within it. But yeah, that I think is a barrier for healing for sure.
Okay. This is our last question before the rapid fire. So, how can clinicians, patients, and industry partners get involved with the American Board of Wound Management Foundation?
Yes. So I would say there's probably three main ways that you can do it. Easy ways, social media. So just find us on social media. Absolutely. That's the easiest way to engage on Instagram and Twitter and Facebook. And yeah, lots of ways to be able to do it through social media. There's contact information on our website. So if you go onto the ABWM or the ABWM Foundation website, there's like a legit phone number to call. There's email addresses. So there's ways to contact through there. And then we also have a newsletter. And so if you're interested in just finding out more about the foundation, we put out a regular newsletter that just gives updates on some of our initiatives. Maybe it highlights a specialist for that month. And so, yeah, so those are probably easy. Social media, contact information on the website, and then through the newsletter. And then we're always present at some of those major conferences. So we've got always present at SAWC in the fall and in the spring. We've got a booth. So stop by. We would love to say hi and just shake your hand and meet you. And we've always got like sample resources there as well. If you're looking to see like, what does the quiz book look like, or what does the study guide look like before you purchase it? So we have people that can talk to you about that. And so stop by and say hi to us. We'd love to meet you.
Okay, wow, thank you. So, rapid fire. If you can deliver one message to every wound care provider in the world, what would it be?
Yeah. One message to every wound care provider in the world. I would say ask great questions and listen well to your patients, because I think they're telling you the story, but they might need you to ask the right questions to get the right story out there. And so every visit with my patients, I'm asking them questions, asking. So ask good questions, be a good listener.
Absolutely correct. What is the one thing every person with diabetes should know about protecting their feet?
Oh, okay. So I use this analogy with my patients a lot, my patients with diabetes, and I say, you need to think of your feet like $1 million feet. Like if you had $1 million bill, which I know doesn't exist, it's fine, wrapped around each foot, that's how I want you to treat your feet. Or like they're made of gold. Like how would you treat your feet if they were that valuable to you? And that is how you should think of your feet. So that's never go barefoot. Always wear the right shoes. Please just look at your feet. Please, please, please just put your eyes on your feet or have somebody else put their eyes on your feet. So yeah, if there was one message, I would say, look at your feet.
Yeah. No,
Just
except, yeah,
look at your
honestly,
feet.
you can't go wrong with saying that. Honestly, yes. Yeah, you
That's
know?
how it works. What would
So,
you say? What would be your
uh,
answer to that question?
for me, don't wait.
Hmm.
Just come in. If you have anything on your feet or anything that goes wrong, just don't wait. Don't ever
Yeah.
try to self-treat, 'cause no.
Yeah, I like that. Yes, right. Yes, because they've got that A1C of 12.8 and that waiting is just gonna be that time bomb that's gonna
Yeah, 'cause they don't
cause
feel it.
problems.
They don't feel it.
Right,
Yeah.
right.
So, as we wrap up today's episode, I want to extend my sincerest thank you to Dawn for sharing her experience, her wisdom, her unwavering passion. You are extremely passionate when it comes to wound care, and I absolutely love it. It's like a
Mhm,
fire, it's like a church of wound care. So, I love it.
mhm.
And as the vice chair of the American Board of Wound Management Foundation Board of Trustees and a longtime leader in the multidisciplinary wound management, Dawn continues to be an amazing champion in education, collaboration, and excellence throughout her profession. So thank you again so much, Dawn.
Well, thank you so much, Dr. Hutchinson, for having me on. This has really been an honor and honored to be here. Thank you.
Thank you. And this is Diabetic Plus Files, where science meets compassion, and together we work to save limbs and change lives. And as we close in on the month of June, yet again, Happy Wound Healing Awareness Month.
Absolutely. Thank you.